We are about to commence our next session on pediatrics. But hey, let me take this opportunity to welcome you all in the India's biggest medical PG prep academic event, the DAMS DVT 2023. It is a concerted effort by DAMS medicos and most importantly, you all who are out there. And it's only because of you this event has become bigger and biggest. We wish you all the very best in achieving your academic goals, and let's remember, apna time apun khud laega. Our next faculty is known for his academic insight. He has accomplished a lot in his professional life. I'm talking about our esteemed faculty for pediatrics, Dr. Sidharth Sethi. Dr. Sidharth is an MBBS from Maulana Azad Medical College, New Delhi. He has done his MD Pediatrics from University College of Medical Sciences, New Delhi. He is a fellow Pediatric Nephrology, AIMS, New Delhi. Also fellow from Cedar Sinai Medical Center, LA, California. He was awarded for outstanding contribution to pediatric nephrology case, Western University 2014, and Cleveland Clinic and Northeast Ohio University 2023. He has performed India's first in 2014 and youngest in 2017 ABO incompatible pediatric renal transplant. He is an ambassador, Indian ambassador, pediatric nephrology for International Society of Nephrology. He has more than 200 indexed publications and chapters to his credit. Let's welcome the very knowledgeable Dr. Sidharth Sethi, MD, FASN, FRCPCH, FISN, FIAP, Senior Consultant, Pediatric Nephrology and Kidney Transplantation, Medanta, the Medicity, Gurugram. He's been Secretary, Indian Society of Pediatric Nephrology 2018 and 2020. We welcome you, sir. Over to you.
Start systemic pediatrics. So today what we'll do is we will be talking about all the important systems, and all of you, if you have not done pediatrics or you want to revise pediatrics over the next 2 hours, I will be telling you all the questions which will definitely come in your NEET PG and inicet. I am Dr. Sidharth Sethi, and let us start. And before we talk, let me ask all of you, why are we all here? Of course, you know, all of us are here for rapid revision, and all of you are here for a visual treat which you have never seen before in the field of medical education. But आज हम यहाँ इसलिए हैं क्योंकि you can see कि ये आपके NEET PG examiner है. And all of you, we are in DAM since last 2 decades. And what I can tell you is, I know what he thinks. No one opens books to ask you questions. What they do is, they ask you what they do in the morning. No one has time to, open Nelson's textbook of pediatrics. What they'll do is, he will only ask what he does in the morning. So I'll tell you what is the passion of your examiners. Okay. So I will tell you what they ask. Okay. And what is always asked in your exams. So they will always ask their own passion. So first of all, let's start with the resuscitation. See, the style of your examiners is, they will ask you, what is your next step? Here is a child on the road. What is your next step? Here is a baby on the road, unconscious. What is your next step? So let us talk about next steps in emergencies. And the first is, of course, resuscitation. You will hear more about neonatal resuscitation in a while, but let me first talk about neonatal resuscitation. In neonatal resuscitation, remember, the ratio is 3:1. So chest compression to bag and tube ventilation. 1 and 2 and 3 and squeeze, and 1 and 2 and 3 and squeeze, and so it's 3:1. Okay, remember it is 3:1. So in 1 minute there are 120 events. Remember this. So they may ask you what happens in 1 minute. We have 120 events. But what about older children, guys? In older children, remember the ratio is, if you are all alone on the road, 30:2. And if you have 2 rescuers on the road, the ratio is 15:2. Okay, so let me first take you to the road. and let me take you to an emergency and let's see what is happening in the emergency. So this is a lady and she found an unconscious child on the road. So what is the first step? To look at the view. The scene should be safe. And let's see what she asked next. Baby, baby. So yeah, of course, you know, as pediatricians, you know, our first and our favorite word is baby, baby, you know. So of course, she will look for responsiveness. Okay, so baby, baby ka matlab hai ask for responsiveness. So let's go back to baby, baby. So she said baby, baby. She looked for responsiveness. The baby is not responsive. 30:2.
3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
30:2.
1, 2, 3, 4, 5,
30:2.
6, 7, 8, 9, 10, 11, 12, 13.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
So let's start and let us talk about, all of you, let us talk about the ratios again. And we said that the ratios, if it's a newborn, it's 3:1. And if in newborn, it's 1 and 2 and 3 and squeeze and 1 and 2 and 3 and squeeze and. So remember, in 1 minute, there are 120 events. And in older children, if you're all alone, the ratio is 30:2. Okay, the ratio is 30:2. Okay, and if you are two rescuers, it is 15:2. Remember this. Okay, so I will show you a video now and I'll show you, here is a lady and she's on the road. She just found an unconscious child. So what will she do? So the first step is to look at the view, whether the view is safe or not. And then she will say baby, baby, to look for responsiveness. So let's see. And as pediatricians, all of you, our favorite, you know, word is baby, baby. So this is what we do. Let's see.
Baby, baby. Greg, she's not breathing. Activate emergency response.
Got it.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
The cart's on its way. Let's start 15:2.
Start compressions.
1, 2, 3.
So you saw once she found a friend. So you saw once she found a friend, they started doing 15:2. So once she found a friend, they started doing 15:2, and you can see he was on this end, she went to the head end. Okay, and now when you are doing 15:2, you can even do two thumb technique also in infants. So let's go further and let us talk about other emergencies like cardiac arrest protocol. Let's talk about other emergencies like cardiac arrest protocol. Okay, so all of you in your PG life, in your MBBS days, has it ever happened to you guys that you had a crush on your senior? कभी ऐसा हुआ है that you had a crush on your senior? Okay, if you had never had a crush on your senior, let me tell you about myself. You know, I hope she is not there in the class right now. with her children. So when I was my first year PG, I had a crush on second year MD medicine. So she was doing her MD medicine. So I always wished for a night duty that, one day I'll go and I'll say hi to her. And one day it happened. I was on night duty and she also had her night duty. And I went and I said hi. And as I said hi, and I was about to say, would you like to have coffee? So what happened is that there was a patient in the emergency who came in, he came in cardiac arrest, adult patient in the emergency cardiac arrest. So she said, okay, Sidharth, I'll just come, I'll talk to you. Can you just wait? So I waited for her. I waited for her for 2 hours, and for the next 2 hours, she defibrillated 10 patients. That was the last time I met her. So, but she taught me something. All of you in MBBS days, in your PG days, learn from everything. That night I learned that the resuscitation, the cardiac arrest protocol depends on whether the rhythm is shockable or not. So which rhythm is shockable? Pulseless VT or VF. Remember, pulseless VT or VF is shockable. And remember, this is common in adults. This is common in adults. So adults usually die of cardiovascular causes. So where we do pulseless VT or VF. Now, everyone in the chat box is asking what happened to my love story later on. I'll tell you, hold on, okay? So remember, for pulseless VT or VF, we give defibrillation. And all of you should know the dose of defibrillation. The first dose is 2 joule per kg. The second dose is 4 joule per kg. And the subsequent doses are 10 joules per kg. So remember, the maximum dose is 10 joules per kg, like adults. Now in children, and after this, after you defibrillate, you continue CPR for 2 minutes. However, in children, all of you know, children usually die of respiratory causes. Children usually die of respiratory causes. So that is why, you will today also hear about neonatal resuscitation. So in children, it's asystole or pulseless electrical activity. PEA is pulseless electrical activity. Okay. So in children, all of you, we do CPR more. We give epinephrine as soon as possible. So remember, in children, we give epinephrine as soon as possible. Okay. We do CPR for 2 minutes. So we do epinephrine as soon as possible. We do CPR for 2 minutes. You can repeat epinephrine every 3 to 5 minutes. Okay. So now a lot of questions in the chat box are what happened to your story. So she's a cardiologist nearby. Okay. I will not tell you where she works. Okay. But this is how your resuscitation is. So in your life, remember, if a child is unresponsive, ideally you should have a AED, automated external defibrillator. You have to decide whether you need to defibrillate or not. Let me show you a video. Let me show you a video. Let me show you a video.
To 15 to 2.
Place electrodes.
The EEG's here.
Place electrodes.
Hands on him.
Place electrodes. Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Check pulse. If no pulse, give CPR.
Kid's got no pulse.
Okay, so all of you, let's go back and let's ask, what did you see in this video? In this video, what you saw was that the machine told rhythm is not shockable, continue CPR. So machine will tell you. I'm getting a question in the chat box. Sir, how do you know it's shockable or not? So again, this is what we told you. If ECG is ventricular, it is shockable. If ECG is asystole or PEA, some pulseless electrical activity, it is not shockable, epinephrine and CPR. Okay, so let's go further and let's talk about more emergencies in the ER. So in the emergency room, now there is a child who has tachyarrhythmia. So remember, tachyarrhythmias are children are classified on the basis of QRS complex. Whether the QRS complex is more than 0.09 seconds or it is less than or equal to 0.09 seconds. Okay, if it's more than 0.09 seconds, it means it's ventricular tachycardia. Okay, now the first step in all the arrhythmias is you have to look for whether this child is in a cardiovascular compromise or not. So ask yourself whether the child is in a cardiovascular compromise or not. Okay, so cardiovascular compromise means the child is in shock or CHF or altered mental state. Shock or CHF or altered mental state. So if he is in a cardiovascular compromise, yes, he is unstable, you will give him a synchronized cardioversion. You'll give him a synchronized electric shock called synchronized cardioversion of 0.5 to 1 joule per kg. If he's stable, he's not in a compromise, he's stable, we will give him adenosine. Yes, the PALS guideline says if this is a monomorphic ventricular tachycardia, you will give adenosine. Now suppose this is less than 0.09 seconds, it means guys, this is not a problem of ventricle. It is either sinus tachycardia, all of us get sinus tachycardia, like all of you are having right now, some tachycardia, or it can be the most common arrhythmia in children called supraventricular tachycardia. So most common arrhythmia in children is supraventricular tachycardia, in which P waves are absent or inverted, heart rate is usually more than 220 in infants and more than 180 in older children. Heart rate is usually more than 220 in infants and 180 in older children. Okay, so when this patient comes to you guys, okay, so what is your first step? Your first step is to do vagal maneuvers. First step is to do vagal maneuvers. So see, suppose someone told you that, I get, paroxysms of tachycardia without any reason. In Hindi, if someone says कि मेरा दिल बार बार धड़क जाता है बिना किसी बात के, तो उसे प्यार नहीं कहते. I don't know. So all of you can tell me what प्यार is in your language. But if someone says that he gets paroxysms of tachycardia, you should say कि get your ECG. Okay, differential diagnosis of प्यार is P से PSVT. Okay, so please say पहले अपना ECG कराओ, कहीं आपको PSVT तो नहीं है. So now once it is PSVT, paroxysms of tachycardia, please look for whether this child is in a cardiovascular compromise or not. Again, look at whether this child is unstable or not. If he is unstable, again give synchronized cardioversion. Okay, and if he is stable, the drug of choice is adenosine. Okay, I can see a lot of anyway synonyms of pyar in the chat box. You youngsters, concentrate. Okay, adenosine. So adenosine, the first dose is 0.1 milligram per kg. So adenosine is the first dose of adenosine is 0.1 milligram per kg. with a maximum dose of 6 milligrams. The second dose of adenosine is 0.2 milligram per kg with a maximum dose of 12 milligrams. Okay, so the first dose is 0.1 milligram per kg, maximum dose is 6 milligrams, or 0.2 milligram per kg is the second dose, maximum is 12 milligrams. Now all of you, what you saw, and I can see a very good question by Dr. Jan in the chat box. See, ventricular tachycardia, pulse is there. If pulse is there, listen to me carefully. Pulse is there. Cardiovascular compromise, give a synchronized cardioversion. So today I told you electric shock is of two types. Defibrillation, a very big electric shock. Very big electric shock, defibrillation. At any part of the cardiac cycle, 2 joule per kg. Synchronized cardiac version, a synchronized electric shock with the R wave of ECG. With the R wave of ECG. Okay? And it is given during a specific part of the cardiac cycle in tachyarrhythmias who have a pulse with cardiovascular compromise. Okay? Let's take you to the next emergency. So guys, I can tell you in your exam, you will have questions like this only. What is your next step? So here is a child from Delhi. This is very common in this part of the year. This is not dengue. This is not dengue. This is purpura fulminans of meningococcemia. So on your screen is purpura fulminans, which is seen in meningococcal shock or septic shock. This is meningococcemia. Okay. So all of you should know what is the management of shock in children. What is the protocol of shock in children? So remember, if I ask you, let me ask you all in the chat box, what is the fluid of choice for shock? If I ask you, what is the best fluid for shock? And I can tell you, all of you will be wrong. Let me ask you in the chat box, what is the fluid of choice for shock? It is not normal saline. If you have available, ideally, you should give balanced crystalloid. So many of you, nowadays we are getting a new fluid called balanced crystalloid. It has less chloride or 0.9% saline or normal saline. Okay, so you give a bolus of normal saline or balanced crystalloid and then you look for the response. If there is no response, suppose there is no response, you can repeat this up to a total of 40 ml per kg. If you are not in ICU, up to a total of 40 ml per kg if you are not in ICU, up to a total of 60 ml per kg if you are in ICU. Okay, why have we changed this? Because this is for India and Africa. This guideline is called the surviving sepsis guideline. This is for India and Africa. So actually what happened in Africa was they found children who got boluses of saline, they died. So if you are in Africa, Africa is a continent where 75% of that continent is not even having electricity. So if you are in Africa, guys, don't give lot of saline. Go to, after 40 ml per kg, go to vasopressors. Go to vasopressors. And the vasopressors of choice nowadays are either epi or norepi. Epi or norepi. Okay. Epinephrine is given in cold shock. It is given in cold shock if you feel there is decreased cardiac contractility. You give epinephrine if there is a cold shock. Norepi is given in warm shock if you feel there is decreased evidence of systemic vascular resistance. If you feel systemic vascular resistance is reduced, suppose bachche ka extremities are warm, but he's in shock. It can also happen in sepsis. So in warm shock, give norepinephrine. Guys, this is the new change now. Now the first inotrope in the ICU, whether it's pediatric, adult, surgical ICUs, it is epi or nor-epi. If there is no response, then we give hydrocortisone because these patients may have adrenal insufficiency. Okay. If there's no response, now this is catecholamine resistant shock. Now there is no response. He is resistant to catecholamines, so we added hydrocortisone. And lastly, you may add vasopressin. And lastly, if there's no response, we go to ECMO, an artificial lung kind of machine. So this is the algorithm for shock. So if there's no response, we go to hydrocortisone. Lastly, we give vasopressin, and then we go for ECMO. Okay, can we go further? Let's go further to the next emergency, guys. And the next emergency is choking. It is choking. So in your exam, definitely, you will have a child who has choked. Choking is common in children around 2 years of age, and the most common foreign body is nuts, kaju, badam. So in children more than 1 year, what you can see on your right side is the Heimlich maneuver. This is a photograph which we gave in obgy textbook many years back. This is a photograph in your obgy textbook. This is called the Heimlich maneuver. But let us look at infants. What do we do in infants? What do we do in infants? What do we do in infants?
Your hand. Find a place where you can sit with the infant, placing them head down and where you're able to support their weight securely. You will then deliver a series of 5 back blows, using the heel of your hand to the center of the back. 1, 2, 3, 4, 5. After this, you will then roll the child over, supporting the head, to deliver a series of 5 chest thrusts, using 2 fingers to the center of the chest. 1, 2, 3, 4, 5. You will continue alternating between 5 back blows and 5 chest thrusts until the object becomes dislodged.
Okay, so you saw that in children less than 1 year, we do 5 back blows and chest thrusts. 5 back blows and chest thrusts. So remember, all of these patients are conscious. If they ever become unconscious, you start CPR. So while doing this, if your patient becomes unconscious, you start CPR. Remember this. Let's go further. And let us talk about dehydration. And I've given this in your handout because I know every NEET PG has a question on dehydration. They will show you a child who has diarrhea and they will ask you, what is your next step? So remember, look, feel, decide. Look, feel, decide. Okay, look, feel, decide. So look at the condition of the child, look at his eyes, look at his thirst, feel the skin pinch. So if everything is normal, this is no dehydration. No dehydration, ORT. Plan A, oral rehydration therapy, where you can also use home-based fluids. Now this is the question, guys, which came in your NEET PG. This is the question which came in your NEET PG. Irritable, sunken eyes, thirsty. I can tell you this will come in your NEET PG and they will ask you, what is your next step? If there are 2 or more of these steps, it is called some dehydration, for which you give ORS 75 ml per kg over 4 hours. So you give ORS 75 ml per kg over 4 hours. Some dehydration. Plan B. Now plan C, this child is completely lethargic, sunken eyes. That's plan C, where what you'll do is, if there are 2 or more of these signs, that's called severe dehydration. And please add this to your page number 855, guys. RL plus 5% dextrose is the fluid of choice. RL plus 5% dextrose. 100 ml per kg. Plan C. RL plus 5% dextrose, 100 ml per kg. Plan C. Okay. For infants, we give RL over 6 hours. For children more than 1 year, we give it over 3 hours. Listen to me carefully. Infants over 6 hours and for older children over 3 hours. Okay, let's go further. And before I take you to more emergencies, guys, I want you to know about some inheritances. In every exam of yours, whether it's NEET PG or inicet, you always get a pedigree. And I'll tell you what is the in thing these days. Okay, so I'll tell you what is the what the examiners have in mind when they are trying to ask you a question. So let me ask you the first pedigree of the day, and I want all of you in the chat box to respond. This pedigree also came in inicet exam, in the last inicet. So whenever you see a pedigree, guys, two things note. First, all the generations have the disease or not. Listen to me carefully. All the generations have the disease or not. If all the generations have the disease, this is dominant. So if all the generations have the disease, this is dominant. Okay. Now my question is to all of you, is there a sex preference? Is there a sex preference? And the answer is no. Males and females are affected equally. So if males and females are affected equally, it is autosomal dominant. मैं फिर से बोलूंगा, all generations have the disease, dominant. No sex preference, autosomal. So the first pedigree, the Mendelian pedigree of the day, is autosomal dominant. And all of you, I tell in each and every class of mine, in all the videos of Back to Basics. So all of you, you should be happy that you have an excellent resource of Back to Basics. So if you ever want to revise any topic, just go to Back to Basics and click on any of the lectures. I have told in each lecture about this mnemonic called dominant VH3. Dominant. D stands for myotonic dystrophy. O is osteogenesis imperfecta. M is Marfan's. I is intermittent porphyria. N is Noonan syndrome. Okay. Okay. A is achondroplasia and adult onset polycystic kidney disease. A is achondroplasia or adult onset polycystic kidney disease. N is neurofibromatosis. T is tuberous sclerosis. Another T, remember all of you, this T came in the last NEET PG. Autosomal dominant ENT syndrome. It's a ENT syndrome. They have ear anomalies also. Treacher-Collins syndrome. VH3, von Willebrand disease. 3H, Huntington's chorea, hypercholesterolemia, and hereditary spherocytosis. Okay. Let's take you to the next pedigree of the day. Are all the generations having the disease? Are all the generations having the disease? No. So this is recessive. This is recessive. Now, someone in the chat box is saying, sir, don't say sex, write gender. Okay. So is there a gender predisposition? Someone in the chat box wants me to say gender predisposition. So is there a gender predisposition? Who is a carrier here, male or female? Who is a carrier here, male or female? Both. So this is autosomal. So there is no gender predisposition. Both males and females are carriers. Autosomal recessive. Okay. So all of you remember, so both males and females are carriers. It's autosomal. Now all of you, I can also say they're consanguineous. Chalo, let's make them cousins. You know, cousins got married, they fell in love, they got married. Now someone in the chat box will say, don't say love, sir. So suppose they have common grandparents. So this male, his maternal grandparents, and this female, her paternal grandparents are same. They have common grandparents. So remember, consanguineous marriages precipitate autosomal recessive traits. Okay. So remember, consanguineous marriages precipitate autosomal recessive traits. So whatever you heard about, remember, whatever you heard about in your biochemistry, whatever you heard about, you know, you heard about some metabolic disorders. Most of the metabolic disorders are autosomal recessive, like cystic fibrosis, alpha-1 antitrypsin deficiency, Wilson's, hemochromatosis, Friedreich's ataxia, Gaucher's. Okay, Gaucher's. Now, in fact, in NEET PG 22, there was a question on Gaucher's. There was a question on Gaucher's in NEET PG 22. So, question was, everyone, there's an infant who has hepatosplenomegaly. So, there's an infant who has hepatosplenomegaly. Okay, hepatosplenomegaly, and bone marrow shows the macrophages are laden with, they are looking like crumpled paper appearance. So macrophages have crumpled paper appearance. What are these crumpled paper macrophages, all of you? Gaucher cells. So this question came in NEET PG. Remember, it is deficiency of enzyme beta glucocerebrosidase. It is deficiency of enzyme beta glucocerebrosidase. This was the first disease for which enzyme replacement was successful. So historically, you know, this was the first disorder for which enzyme replacement therapy was successful. Now let me take you to the in thing, guys. And the in thing is a disease called SMA, spinal muscular atrophy. But before that, let's ask you a question, guys. In my DVT, I will cover everything you need to know. So everyone in the chat box, tell me the answer. Which of the following is autosomal recessive? And let's have a chat box running, and I can see everyone in the chat box is right. Cystic fibrosis is autosomal recessive. Rest all of these are autosomal dominant. And I can see the chat box is on fire. And I love you all. Everyone in the class is right. Can I give you a round of applause? And this is what we want all of you to do, guys. And I'm very happy. Everyone in the class is right. Okay. So rest all of these disorders are autosomal dominant. So let us talk about a very important disease called spinal muscular atrophy. SMA, spinal muscular atrophy. It is also called floppy baby syndrome. It's also called the floppy baby syndrome. Floppy baby. So here is a baby who is born floppy. So parents say, Doctor साहब हिलता नहीं है, हमेशा टुन रहता है. हिंदी में he is always टुन. You know, टुन. Now someone will ask me, sir, हिंदी में टुन बोला आपने. So all of you, can you please tell your colleagues what does tun mean in other languages? So he is completely floppy. And even during pregnancy, the fetal movements were very less during pregnancy. Okay. So this baby was always in the bed in a frog-like posture, always like this in a frog-like posture. And one day he died. He aspirated. So remember SMA or spinal muscular dystrophy, atrophy is autosomal recessive. Type 0 is very severe. They all die. Type 1 is also very severe. It is called Wernicke-Hoffmann syndrome. One day they aspirate and die. It is a disease of the spinal anterior horn cell. Okay. It is a disease of the spinal anterior horn cell. So can anyone, I want all of you to tell me in the chat box, will this patient have upper motor neuron weakness or lower motor neuron weakness? Upper motor neuron or lower motor neuron? Lower motor neuron weakness. So this child gets lower motor neuron weakness, atrophy, flaccidity, areflexia. Everyone is right. Atrophy, flaccidity, areflexia, and fasciculations. Now this is a favorite question of your examiners. Every NEET PG inicet will have a question like this. Can you see this tongue? Can you see this trembling movement in the tongue? Can you see this? This is fasciculations. Fasciculations are best appreciated in the tongue. Okay. So this question came in the last inicet. Fasciculations are seen in SMA or myasthenia gravis. So fasciculations are seen in spinal muscular atrophy. Let me show you this child's legs. Let's look at his legs. See, his legs are completely outwardly deviated. He's completely hypotonic. There is no tone at all. See, there is no tone at all. This is typical of SMA. Why am I talking about SMA? Because the gene therapy is successful. Now there are 3 drugs. Nusinersen, onasemnogene abeparvovec. Yes, you have to remember. Anyone in the chat box, don't write, Yaro, ye yaad rakhna hai, nahi rakhna. I see sometimes in the chat box you say, Yaro, likhna hai? Yaro, do I need to write this? So yes, you have to write this. This is US FDA approved, onasemnogene abeparvovec, which comes by the trade name of Zolgensma. Okay. Risdiplam. So these drugs are available and they are US FDA approved. This is now the world's costliest drug. So this used to come around 16 crore rupees. Now the rate has increased. And you know, we are from Delhi, guys. So, you know, our chief minister also gave recently this drug to a child, and they saved the child from Delhi by giving this drug, which is now worth 17.5 crore rupees. So this is the photograph of our chief minister. Okay. So yeah, all of you know. So let's take you to the next inheritance of the day, guys. This is my favorite inheritance. Are all the generations having the disease? Anyone? Are all the generations having the disease? No. So this is recessive. This is recessive. Is there a gender predisposition? Guys, is there a gender predisposition? Yes. Only poor males. You can see poor boys. So guys, girls, you know, girls don't have any problem. You know, they look normal. Females are carriers. They look normal. And poor boys are affected. Poor boys are affected. Poor boys. Yes, poor boys. Okay. So boys have a lot of problems, guys. You know, no one understands. People think, you know, girls only have problems. Guys have so many problems. Look at mosquitoes, guys. You must have seen, you know, mosquitoes, male mosquito. What is the job of a male mosquito? His job is to fertilize and die. Only females survive and they bite. I mean, the mosquitoes. So see, life is bad for boys. You know, nature made it like this. These are all the boys who get the disease, like Duchenne's muscular dystrophy is seen in boys, Becker's, hemophilia A, hemophilia B, G6PD deficiency, Wiskott-Eldred syndrome, color blindness, Lesch-Nyhan syndrome, chronic granulomatous disease is X-linked recessive. Okay. Okay. So let's show you a question from NEET PG 22. And it's before I show you this question, I have this boy to show you. Guys, here is a boy, and this boy actually came to us with a problem that he has trouble standing up from sitting position. So I'll show you a video and tell me what's happening here. We are asking him to stand from sitting position. I'll again play for you. He's climbing on himself. See, he's climbing on himself. This is called the Gower sign. Gower. This is called the Gower sign. So he has a problem in proximal muscle weakness. Gower sign is a sign of proximal muscle weakness. Gower's is not Duchenne's. Gower's means this patient has proximal muscle weakness. Okay, remember this. Okay, so let's talk about Duchenne's, the most common hereditary neuromuscular disease. So this question came in NEET PG, guys, and all of you, you know, came to me and you said, sir, in my NEET PG, there was a question. A 2-year-old boy has proximal muscle weakness, frequent falls. He's not able to stand from squatting position. And this is the muscle biopsy. Let me zoom this muscle biopsy for you. So this is Duchenne's. What do you see in this muscle biopsy? You see within the muscle fibrils there is increased connective tissue, increased interfibril connective tissue. So what is the earliest feature of Duchenne's? Increased interfibril connective tissue. Okay, increased interfibril connective tissue, and later on it becomes fat. So this is Duchenne's, and most of them die in their teenage life. So most of the Duchenne's die in their teenage life. They don't survive beyond teenage. Recently there's a US FDA new gene therapy also approved for Duchenne's, but most of them die in their teenage life. Okay? Okay, so remember this. Duchenne's. Okay, let's take you further to one more question from a favorite question. So NEET PG में लड़के आएंगे. Okay, male gender will come. Okay, male gender will come in NEET PG. So here is a boy who has a triad. Anyone in the class? Which condition has a triad of eczema or atopic dermatitis? Which condition has a triad of eczema or atopic dermatitis, thrombocytopenia and immunodeficiency? Thrombocytopenia and immunodeficiency. X-linked recessive WAS, Wiskott-Eldridge syndrome. X-linked recessive Wiskott-Eldridge syndrome. Eczema, thrombocytopenia, immunodeficiency. Mutation in the gene WASP. Mutation in the WASP gene. Wiskott-Eldridge syndrome protein gene. Okay, again X-linked recessive. So let's take you further to the next pedigree of the day. And now I will not speak anything. I want you to speak now. I'll keep quiet now. मैं नहीं बोलूँगा. अब आप बोलोगे. All the generations are affected. Dominant. There is no doubt. All the generations are affected. Dominant. But the question is there a gender predisposition? Is there a sex predisposition? I couldn't help it. Yes. Affected male gives the disease to all daughters. Affected male is giving the disease to all daughters. X-linked. X-linked. So how did I identify this? Look at, so all of you, whenever in your exam, listen to me carefully. Whenever in your exam, you are marking dominant, you have to see this. If there is an affected male, he is giving the disease to all daughters, it is X-linked. Affected father gives the disease to all daughters, none of his sons. So if you want me to tell you in single sentence, there is no father to son transmission, because father gives Y to his sons. Father always gives Y to his sons. Okay. So what are the examples of X-linked dominant inheritance? Hypophosphatemic rickets. Please write it down, all of you. I want all of you to write also. I don't want to spoon feed you and give everything in written. Please open your pen, write hypophosphatemic rickets, Rett syndrome, inconsentia pigmenti, Aicardi syndrome. Okay, Rett's inconsentia pigmenti, Aicardi syndrome. Noted? Noted? Now listen to me carefully. These three syndromes, Rett's, inconsentia and Aicardi, are only girls. Why? Rett's, inconsentia and Aicardi are only girls. Why? Because the male fetuses die. These three syndromes are so severe in male fetuses that they die. These three syndromes are lethal in male fetuses. They're lethal in male fetuses, so they die. So now I will not show you a PYQ. I'll just tell you, NEET PG 22, which syndrome is only seen in girls? Rett syndrome. All of you, I'll show you a very sad pedigree. I'm very sad today because this pedigree shows no boys. And please correct this picture, all of you, because this picture was in your Nelson's textbook and they have given a wrong picture. Now, what is this pedigree? I can only see girls, guys. I can only see girls. Where are the guys? Huh? Where are the boys in this pedigree? Kahan gaye ladke? Mar gaye. So these must be the male fetuses which died. Okay, so this is a typical X-linked dominant pedigree which is lethal in male fetuses. So only females survive. For example, Rett's inconsentia Aicardi syndrome. Okay, Rett's inconsentia Aicardi syndrome. Okay, remember this. And all of you should know that now there is a new drug of choice for Rett syndrome. And this is an in thing now. You should know that recently the US FDA has approved a new drug for Rett syndrome. This is the only drug available proven to help in Rett syndrome. It's called trofinetide. Trofinetide comes as an oral solution for children 2 years and older. Trofinetide comes as an oral solution for children 2 years and older. Trofinetide. What is trofinetide? Remember, it is a synthetic analog of IGF-1. Remember, trofinetide is a synthetic analog of IGF-1. Okay? IGF-1. So in Rett, there's a problem in the brain connections. So this helps in the brain connections. Synthetic analog of IGF-1 approved for patients 2 years or more. Okay, approved in patients 2 years or more. Okay, let's go further. And I talked about Mendel. I told you, Dr. Mendel came, he just told us 4 things. AD, AR, X-linked recessive, X-linked dominant. Now here is a child, all of you, who has a very thick upper lip. What will you think of? Thick upper lip, a very prominent lips. You'll think about Williams syndrome. So this is Williams syndrome. What is Williams syndrome? Remember, it's 7q11.23 deletion. It's a micro deletion. Williams syndrome. Okay, they have Alpine face. So remember, Williams syndrome is a micro deletion syndrome. They have Alpine facies. Okay, so remember, how do we differentiate Williams from fetal alcohol? Williams have thick upper lips and the lower lip. They have thick lips. They have supravalvular aortic stenosis. So they have supravalvular aortic stenosis, peripheral pulmonary stenosis, supravalvular aortic stenosis, and hypercalcemia. And they have hypercalcemia. Alpine facies, supravalvular aortic stenosis, peripheral pulmonary stenosis, and hypercalcemia. Okay, noted? How do we diagnose microdeletions? By a FISH. So remember, to diagnose microdeletion syndromes, we do FISH. Fluorescence in situ hybridization. Okay, so we diagnose microdeletions by FISH, fluorescence in situ hybridization. Okay, remember this. Okay, let's go further, and this is again a question from NEET PD 2020. Shoot, let's run the chat box. A child who has very coarse facial features, hypercalcemia, and supravalvular aortic stenosis is, of course, the chat box is running, everyone is right, Williams syndrome. You are completely right. Okay, DiGeorge syndrome has this is also very important, just listen to me carefully. DiGeorge syndrome has absent thymus, absent parathyroids. Just remember one more point. Another microdeletion syndrome 22q11 deletion, D George, is absent thymus, absent parathyroids. Okay, absent thymus, absent parathyroids is D George. Okay, catch 22 mutation, you are completely right. Let's go further, guys, and we cannot go further without talking about hand washing. We need to talk about hand washing. You cannot survive without hand washing. So, you know, we all survived the COVID era, so we should know about the hand washing. And the mnemonic for hand washing is PDF ITR. So all of you, when you get your PG, you will earn a lot of money. You will put a lot of money in the income tax department. I am just joking. You are not here to earn money. You are here to follow your passion. Someone in the crowd today wants to be a surgeon. Someone wants to be a pediatrician. Someone wants to be a gynecologist. So you are here to earn money through your passion. Okay, so that's what you want to do. So this is a photograph from my in fact from my hospital's ICU, and in my hospital there are some nurses, their job is to look at the doctors. They have to see in the ICU, there's a camera on the wash basin, and she has to see how many minutes we spend to wash hands. And if we wash hands for a few seconds, you know, we are supposed to wash hands for 2 minutes. If we don't do that, we get an email. Doctor, kal tumne kam haath dhoye the. So P, palm to palm. D, dorsum of palms. F, interlocking of fingers. I, interlocking of knuckles. T, thumb. Thumb is also clean in the rotational movement, and R is by rotational movement you clean the tip of your fingers. I'll again say I. So let's start from P. Palm to palm, dorsum of palms, interlocking of fingers, interlocking of knuckles. By rotational rubbing you clean the thumbs, and by rotational rubbing you clean the tip of your fingers. Okay, remember this, all of you should know. Okay, PDF ITR. So let us talk about, you know, no lecture, no class can finish without talking about something, you know, which changed our lives, COVID-19. So let's first talk about, is breastfeeding safe in COVID-19? And the answer is yes. COVID-19 is not a contraindication for breastfeeding. Okay, breastfeeding is safe. The only thing is, like other things, mother has to observe the proper respiratory etiquettes. So if mother has COVID-19, she has to observe the proper respiratory etiquettes. Now let's talk about children. I'm a pediatrician. I will only talk about children today. Okay, so let's first talk about vaccines in children. So in children more than 6 months, in the West they have mRNA vaccines. So in the US they have mRNA vaccines. One is called the Pfizer, the other is called Moderna. So in the US now, the COVID-19 vaccines are approved for children more than 6 months. So remember, in US the COVID-19 vaccines are approved for children more than 6 months. Okay. There is only one main complication of these vaccines is myocarditis. So remember, especially adolescents can get myocarditis after the second dose of this vaccine. So remember, adolescents may get myocarditis after the second dose of this vaccine. Now, there are some vaccines in adults, like the J&J vaccine. It is the adenovirus vaccine. And most of us got Covishield. And as you can see, Covishield is chimpanzee adenovirus Oxford vaccine. Chimpanzee adenovirus Oxford AstraZeneca vaccine. Okay, we all got Covishield, which is for adults. Now in children, remember 3 more names I have given you in your handout. Corbevax, a protein subunit vaccine. Corbevax, a protein subunit vaccine. Covaxin. Now, for children more than 12 years, Covaxin is an inactivated, killed vaccine for children more than 12 years. And for all of my patients who are immunocompromised more than 12 years, I gave them Covaxin. Then there's a Zydus vaccine, which is a Zydus cadila DNA virus vaccine. Just remember the name, Zydus cadila DNA vaccine for COVID-19. So why are we talking about children? Because children got completely different disease. Guys, you know, adults got lung COVID, they got pulmonary COVID. But in children, this is the peak of adults. This is the peak of adults, adult COVID peak. Now, when the adult COVID peaks falls, what happens is the children peak comes and children get MIS-C, multisystemic inflammatory syndrome in children with COVID. Multisystemic inflammatory syndrome in children with COVID. I used to call it MISC, but then I saw all of my friends in the US call it MIS-C. So I started calling it as MIS-C, multisystemic inflammatory syndrome in children with COVID-19. So I can tell you guys, in the last 3 years, we saw so many epidemics of COVID-19 in children also. We saw epidemics of Kawasaki disease. So it all started from Europe. In Italy, there was an epidemic of Kawasaki. In America, and then in India, in Mumbai, I can tell you 2 years back in my ICU, all children had the same diagnosis, MIS-C. So all of you, what is the WHO definition of MIS-C? So WHO says 19 years, a child less than 19 years with fever of at least 3 days. Okay, less than 19 years, fever of at least 3 days, and 2 of the following. 2 systems should be involved. It is multisystemic. It could look like Kawasaki or hypotension and shock. Evidence of myocardial dysfunction in the form of myocarditis, valvulitis, coronary abnormalities. Evidence of coagulopathy. In fact, diarrhea was the most common symptom of MIS-C. Okay, so 2 system involvement and elevated acute phase reactants. There was no other cause of infection and COVID-19 was positive. Okay, elevated acute phase reactants including CRP, ESR, procalcitonin, no other cause, and evidence of COVID-19. I can tell you guys, I saw so many children in COVID who had fever for like 3 weeks. And when we got their IgG COVID-19, we found they had an autoimmune response to the, like a cytokine storm to the COVID-19. So how do we treat MIS-C? So if it's just a mild, like I saw a lot of children in my clinic also in COVID-19 who had mild kind of features, fever chal raha hai. So for mild COVID-19, MIS-C in children, we give low dose steroids, 1 to 2 milligram per kg per day for 3 to 5 days. So we give 1 to 2 milligram per kg per day for 3 to 5 days. Mild MIS-C. Okay. Now, if a child looks like Kawasaki disease, and again, even in MIS-C, there is a risk of coronary artery aneurysm. Yeah. So even in COVID-19 in children, we found coronary artery aneurysms. So if a child looks like Kawasaki, see, COVID suddenly came in our world. We never knew about COVID. So we knew about Kawasaki disease. So we treated children just like Kawasaki. So we gave them IVIG, 2 grams per kg, maximum dose of 100 grams. Okay. And low dose steroids, 1 to 2 milligram per kg for 3 to 5 days. Low dose steroid, 1 to 2 milligram per kg for 3 to 5 days. Okay. Now, if a child came with MODS, and I was telling you, 2 years back, all the children in my ICU I saw many children dying from Haryana. A child came to us from Haryana. He was in myocardial failure and he died. He had coronary artery involvement. So for shock and multi-organ failure, we give high dose steroids for 3 to 5 days. So high dose steroids is the drug of choice for severe COVID-19 in children. And IVIG 2 grams per kg. Okay, let's go further. So let me tell you about the IAP. Let's take you to some infections and other systems. So in children, we also follow the Indian Academy of Paediatrics immunization schedule. So this is the schedule I have given you in the handout. Remember, a favorite question of your NEET PG examiners, 2 important points. Number 1, Now we are all passionate about this pneumococcal vaccine. So we give pneumococcal conjugated vaccine at 6, 10, 14 weeks. We advise rotavirus vaccine. So this question came in your NEET PG last year. Which vaccine has a complication of intussusception? Rotavirus. So rotavirus vaccine has a complication of intussusception, but the new generation vaccines which we use, they have a very little risk. So we give rotavirus vaccine. So this is the schedule. Please note it down, but just note down especially this part, that at 10 to 12 years now we give T, small AP, low dose diphtheria and low dose acellular pertussis, low dose diphtheria and low dose acellular pertussis. We also advise now human papillomavirus vaccine to girls for cervical cancer. So let's take you now to cardiology, and this is a favorite question of your examiners. A 2-year-old boy with fever, conjunctival inflammation, swollen palms and soles, a rash, and strawberry tongue, Kawasaki disease. You're right. So our next topic is Kawasaki disease. What is Kawasaki? Most common medium-sized vasculitis in children. Not overall, I said most common medium-sized vasculitis in a child. It is the most common acquired heart disease in US, Japan and Chandigarh. Most common acquired heart disease in US, Japan and Chandigarh. Okay, because America, everyone knows if a child has fever and rash, think about Kawasaki. Japan, Dr. Kawasaki was a Japanese. He died in COVID-19 at an age more than 95 years old. And because of Dr. Kawasaki, there's a lot of awareness in Japan. Chandigarh, the head of Department of Paediatrics of PGI, he's a pediatric rheumatologist. He's the father of pediatric rheumatology in our country. So because of him, there's a lot of awareness about Kawasaki disease in Chandigarh. Kawasaki disease, children are less than 5 years. 80% of children are less than 5 years. Remember, 80% are less than 5 years. It is never seen in adults. Remember, Kawasaki is never seen in adults. And what is this on your screen? 20 to 25% of patients of Kawasaki are at a risk of coronary artery aneurysm. 20 to 25% of patients of Kawasaki are at risk of coronary artery aneurysm. So this is a coronary angiography on your screen. Okay. So all of you should know about the classic criteria. And guys, I just now told you the criteria of Miss C. Miss C was less than 19 years, fever of at least 3 days. But in Kawasaki, it's 5 days. And any four of these five criteria, changes in the extremities. Please note, peeling of the fingers is seen in 2nd to 3rd week of illness. A rash, conjunctival inflammation, erythema of lips, strawberry tongue, cervical lymph nodes. It's mostly a unilateral big cervical lymph node. So why are we talking about Kawasaki? Because they can get aneurysms. And this is, it is very passionate story. If you look at what happened in 1967. In 1967, Dr. Kawasaki made this sketch. And it is history, he made this sketch with pencil in his copy that, my friends, I saw a lot of Japanese children with fever, arthritis, cardiovascular problems, and he made this pattern. And can you please look at thrombocytosis? In Miss C, in COVID-19, there is thrombocytopenia. But in Kawasaki disease, there is thrombocytosis. And can you please note this? That aneurysms and desquamation are seen in the subacute phase, in the 2nd to 3rd week of illness. So remember, aneurysms occur late, in the 2nd to 3rd week of illness. Okay. So if Kawasaki is there, we give IV immunoglobulin 2 grams per kg. It has to be given during acute phase, which is the first 10 days of illness. It has to be given during the acute phase, and we have to give oral aspirin. It's high dose aspirin, 100 milligram per kg per day, till the child is afebrile for 48 hours. Till the child is afebrile for 48 hours, we give him oral high dose aspirin. IVIG reduces the risk of coronary artery aneurysms to 4 to 6%. The initial risk was 20 to 25%. Now it reduces the risk of coronary artery aneurysms to 4 to 6%. And we discharge this child, remember, we discharge this child on low dose aspirin. It's a low dose aspirin, 3 to 5 milligram per kg per day. 3 to 5 milligram per kg per day. So we give them high dose anti-inflammatory aspirin, and we discharge them on low dose anti-platelet dose of aspirin. Okay. Yes, drug of choice is IVIG. Okay. Okay. So all of you, let us talk about what is resistant. Your examiners really like to ask you what is resistant. Okay. So resistant means fever is either persisting or it recurs within 36 hours of IVIG. Okay. Fever is either persisting or recurs. So what are the options we have? And guys, these are the drugs we use in COVID-19, okay, because we never knew how to treat COVID-19 in children. So we gave steroids. You can add methylprednisolone. So in these children, you can add methylprednisolone. You can repeat a dose of IVIG. You can use TNF blockers like etanercept, infliximab. You can use interleukin-1 blocker like anakinra. Anakinra is an interleukin-1 blocker. You can use cyclosporine or plasmapheresis, and this is what we used in other cases of COVID also, in MIS-C. Cyclosporine plasmapheresis. So you can try these drugs in resistant Kawasaki disease. Okay. So we give aspirin in all of these patients when we discharge them, and we do serial echocardiographies because aneurysms can appear later also. So we give at least, oral aspirin for the next 3 to 6 months, even in MIS-C. Okay. So this is a question which came in your recent INICT, guys. What will you do? I will not speak. You will speak. A child with fever for 6 days, strawberry tongue, desquamation, and he even has a coronary artery aneurysm. You can see strawberry tongue, you can see conjunctival inflammation. Very rarely, 1% of Kawasaki can recur, rarely. So of course you'll give IVIG, there is no doubt about it. It reduces the risk of aneurysms to 4 to 6%. Let's go further. So we always talk about this in the back to basics, guys. I talk about this every day. So all of you just go to back to basics. All of these lectures are there on the back to basics. And I have tried to categorize them by their specialties and by the topics. It's all topic wise. Okay, you can see 2 Sidharth Sethis, by the way, here. Completely, double role here. Let's go further and let's talk about North India. Let's take you to another vasculitis, guys. Today morning, a child just got up in the morning and he got this purpura. Palpable purpura. Listen to me carefully. Palpable purpura over his extensors. So this is the most common vasculitis in children. Now listen to me carefully. The most common vasculitis in children, Hinot-Schönlein, which is also called IgA vasculitis. Most common vasculitis in children. It is the most common cytoclastic vasculitis. It is the most common leukocytoclastic. Matlab, WBCs are invading the vessel wall. WBCs are invading the vessel wall. Leukocytoclastic. Yes, very good. Someone in the chat box. Most common small vessel vasculitis also is Henoch-Schönlein purpura. Now the other name. So now we say, can you see IgA deposition in the vessels? So now we don't say Henoch-Schönlein, we say IgA vasculitis. Okay, it can be seen in adults. I'll come back to this NEET PG question later on. So it can be seen in adults. So the definition does not talk about age. So this is the definition by the European definition. It's called EULAR, European League Against Rheumatism. So European League Against Rheumatism says you should have a palpable purpura without coagulopathy or thrombocytopenia, and any of these, pain abdomen, arthritis, biopsy showing IgA deposits, kidney involvement. This is IgA vasculitis. So why am I talking about this? Because kidney may be involved. In 30 to 50% of these patients, kidney may be involved within almost 6 weeks of illness. And mostly in kidney, you will see some RBCs in the urine. Microscopic RBCs, microscopic hematuria, with or without proteinuria. Microscopic hematuria with or without proteinuria. Okay, sometimes they can get a nephrotic syndrome kind of presentation. A lot of protein in the urine. Isko kehte hain nephrotic, nephritic presentation. If you see a lot of proteinuria, you will do biopsy. Biopsy we do if there is a lot of protein loss in a child with HSP. Because in the biopsy we are looking at mesangial proliferation. It's mesangial proliferation and IgA deposition in the mesangium. Guys, can you please write in the chat box for me? Mesangium. It's mesangial proliferation and deposition of IgA in the mesangium of the glomeruli, where the drug of choice is oral prednisolone. Even for severe pain abdomen, also, you can give oral steroids. Okay. So even for severe pain abdomen also, you can give oral steroids. Now rarely these children can present to you as RPGN. As RPGN, what is RPGN? Rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. कुछ दिनों और हफ्तों में किडनी खराब हो गई. In English, there was a rapid deterioration of kidney function over days, 2 weeks. And in the biopsy, we see crescents. And the drug of choice for crescents is methylprednisolone. High dose steroids, we give methylprednisolone for crescents. So drug of choice for crescentic GN is methylprednisolone. So let's ask you a question from NEET PG. So this is the question. A child with severe pain abdomen, HSP, you can give steroids. Okay, cool. Let's go further. And let's take you to congenital heart disorder. So what I'll do next now is, see, all of us at DAMS, it is not like, I'm teaching you for the first time. All of us faculty at DAMS have been doing this since 20 years. So I'm in DAMS since 2 decades now. So we know the trend. And I can tell you in the last 5 years, what I'm seeing is that they ask questions. They will show you some X-ray. They will give you a clinical history of a congenital heart disease. So let's talk about some congenital heart disorders and the classification of congenital heart disorders. So congenital heart disorders are of 2 types, acyanotic and cyanotic. They are of 2 types, acyanotic and cyanotic. So most of the acyanotic defects are left to right shunts. So remember, most of the acyanotic defects are left to right shunts, like ASD, VSD, PDA. Okay, ASD, VSD, PDA. Okay, atrial septal defect, ventricular septal defect, and PDA. Okay, so they have increased pulmonary vascularity. Okay, now let us try to divide cyanotic heart defects. So all of you, please, I want all of you to make some notes also. And let me write for you classification of cyanotic heart defects. And I'm seeing that a lot of questions come on classification of cyanosis. So please open, take your pen, write in the notebook classification of cyanosis. Okay. I want you to at least write in the workbook. Okay. So we divide the cyanosis based on the PBF, pulmonary blood flow. Whether the cyanosis, the pulmonary blood flow is increased or reduced. Whether the pulmonary blood flow is increased or reduced. When it is increased, it's called plethora. When it is increased, it's called plethora, which means the pulmonary vascularity is very good on the X-ray. When it is reduced, the lungs are looking black. It's called oligemia. Now, cyanosis with plethora, the first example is truncus arteriosus. There's a single vessel above our heart. It's called truncus arteriosus. The second is TGA plus VSD. And the third is TAPVC, totally anomalous pulmonary venous connection. So in the next 1 or 2 minutes, I'll take you to TAPVC, totally anomalous pulmonary venous connection. So the pulmonary venous blood is totally anomalously going to the right heart. Now oligemia, I can further divide it into two. Those children who have massive cardiomegaly. Remember, massive cardiomegaly with left ventricular hypertrophy is tricuspid atresia. Left ventricular hypertrophy is tricuspid atresia. And a massive heart, a box-shaped heart or a balloon-shaped heart is Epstein's anomaly. Massive heart, a box-shaped heart or a balloon-shaped heart is Epstein's anomaly. Okay, and if you have oligemia with a normal size heart, this is called the Fallott's physiology. Mostly it is TOF, but there are many other causes. So we say this is called the Fallott's physiology. Okay, oligemia with a normal size heart, single second heart sound. They have a single second heart sound, Fallott's physiology. So let's first talk about TAPVC. I'll talk about TAPVC. I'll take you to Epstein's and many more. Now, what is TAPVC? We told you the pulmonary veins are anomalously joining the right side. They can join the superior vena cava, they can join the portal vein, or they can join the coronary sinus. Remember, the most common is supracardiac. 50% of the times it is supracardiac, in which heart looks like a figure of 8 or a snowman's heart. Heart looks like a figure of 8 or a snowman's heart. Infracardiac is the most severe. Remember, infracardiac is the most severe, in which the heart looks like a ground glass appearance. Ground glass appearance. Okay, some of you want to see the last slide. Just see it for a few seconds. Okay, so we said supracardiac is the most common, where pulmonary veins join the superior vena cava. Infracardiac is the most severe, in which the heart looks like a ground glass, white out lungs. Ground glass, white out lungs. Remember, this is the most common. Yeah, infra, you are completely right. Infra is the most severe, which you can see in second one. Infra, this one. This is the most severe. Now remember, this is the only congenital heart disease in which all chambers of the heart have same oxygen saturation. Dekho, 85, 85, 85, 85. So all chambers of the heart have same oxygen saturation. So remember, in your exam, you can have two X-rays. Number one like this, supracardiac, figure of 8, or snowman, like a snowman. I can make a nose here. Or a white out ground glass lungs, infracardiac. So if you see cyanosis with white out lungs, think about infracardiac TAPVC. Let's go further, guys. Let's go further. And let's talk about this massive heart called abscenes. So abscenes is a massive heart, a box or a balloon shaped heart. Remember maternal lithium. Please don't forget this. Maternal lithium. If mother takes lithium during pregnancy, baby can get abscenes anomaly. Okay. Always remember TGA, transposition of great arteries. The most common cyanosis in an infant. Most common cause of cyanotic heart disease in an infant is actually TGA. TOF is after first year of life. And you can see this X-ray called egg on side or egg on string. So in TGA, you see egg on side or egg on string appearance. Okay, egg on side or egg on string appearance. Now let us talk about the most common cyanotic heart disease overall. Most common cyanotic overall and after the first year of life. TOF. So remember, the most common cyanotic heart disease overall and after the first year of life is TOF. There are 4 points. Number 1, infundibular pulmonary stenosis. So there is pulmonary stenosis. Right ventricular hypertrophy. Aorta is overriding the septum. Aorta is overriding the septum. And last, it's a VSD. It's a perimembranous VSD. Because of the pulmonary stenosis, right ventricular pressure is increasing because of the pulmonary stenosis. So the pressure increases so much that the shunt becomes right to left. See, the shunt in TOF is right to left. So the shunt in tetralogy of Fallot is right to left shunt. Impure blood goes to the system X. So these children have a problem of cyanotic spells. So babies of TOF have a problem of cyanotic spells. So guys, I can tell you every exam of yours has this X-ray. What is this X-ray showing? Can anyone tell me? Coherence about a boot-shaped heart. So in your exam, they may show you a cyanotic child with a boot-shaped heart. So in French, it's called coherence about. Now, what causes the boot? What causes the boot? See, the apex is uplifted because of right ventricular hypertrophy. So remember, right ventricular hypertrophy causes the boot because there is uplifting of the apex. Okay, so it looks like a boot because of uplifting of the apex. Cool. So remember, these children commonly have cyanotic spells. And this is the photograph of very famous cardiac surgeon called Blalock and his friend. She was a pediatric cardiologist. So she was a pediatric cardiologist. Her name was Tosek. So Blalock, so this was a shunt made by two friends, Blalock and Tosek. So don't take me otherwise. This was a shunt made by two friends, a surgeon and a cardiologist. There's a third guy here also called Thomas. Nobody talks about him because there was a lot of racism in that time in the US. So ideally it should be called Blalock Thomas Tosek shunt. So if a child has spells, again, if he gets recurrent cyanotic spells, so you should give him medicines followed by a Blalock Tosek shunt. So on your left is a classic Blalock Tosek shunt where we are joining the subclavian artery to the pulmonary artery. Okay, so a lot of blood, pure blood goes to the lungs, which is good. Okay, but nowadays we do modified Blalock Tosek shunt where we put a Gore-Tex tube between them. So nowadays we put a Gore-Tex tube between the subclavian and the pulmonary artery. So we don't put them, previously we used to put end to side. End ko laga diya side pe of PA. But now we put a tube called Gore-Tex tube between the two. Okay, so nowadays we do Blalock Tosek shunt. Let's go further and let's take you to the respiratory system, guys. Now in respiratory system, before I take you, this is the under 5 mortality all over the world. I'm not talking about India because that will be covered in PSM. So as you can see, the biggest pie is prematurity. So if you ask me what is the most common cause of under 5 overall mortality in the world, it's prematurity. But after the first month of life, pneumonia. Remember, after the first month of life, pneumonia is the most common cause of under 5 mortality in the world. Pneumonia. Let's show you a child, guys. So what was happening here? Stridor. So let's talk about fever with stridor. So in your ENT class, all of you read that fever with, so stridor overall is, laryngomalacia is more common. But the most common cause of fever with stridor, it was stridor, guys, is croup. So remember, the most common cause of fever with stridor is croup. Laryngotracheobronchitis, which is viral, which is caused by para-influenza virus. It is caused by para-influenza virus. Okay. And on your screen is a typical X-ray of croup called the steeple sign. The typical X-ray of croup called the steeple sign. So here is a child who had a viral prodrome and stridor. A child with viral prodrome and stridor. He also had a Barkey cough. This child also had a Barkey cough. So drug of choice for mild croup is high dose DEXA. So remember, drug of choice for mild croup is high dose DEXA. Single dose high dose DEXA of 0.6 milligrams per kg. Drug of choice for moderate to severe croup is nebulization with racemic epinephrine. So drug of choice for moderate to severe croup is nebulization with racemic epinephrine. Remember that. Okay. So croup can cause fever with stridor. A viral illness. It's a viral illness. Let's take you to a bacterial illness now. What is this? A bacterial illness called epiglottitis. A severe bacterial illness. Now all over the world, strep pyogenes leads, followed by strep pneumoniae. So all over the world, it's strep pyogenes followed by strep pneumoniae. Only in India, H influenza is common. And this is the typical lateral X-ray showing the thumb sign. So this is the typical lateral X-ray showing the thumb sign of epiglottitis. Now, the mainstay of treatment is airway. You have to give airway. Mainstay of treatment is airway, followed by ceftriaxone. So you give IV ceftriaxone, a third generation cephalosporin, ceftriaxone for bacterial illnesses. Okay. Now, another very important cause of fever with stridor is this. What is this on your screen, guys? If NEET PG loves to ask about, questions like what is your next step? You can see a child with white membrane in the throat. Another cause of fever with stridor. Of course, this is an emergency condition. Diphtheria. So I'll tell you what to do, but let me talk about a child who has a bull neck and a white membrane in the throat. Laryngeal diphtheria. So how do we treat diphtheria? Let's talk about how do we treat diphtheria. So I've given you in the handout that to treat diphtheria, you have to, for the circulating toxin, we give antitoxin, and for the bound toxin, we give antimicrobials, erythromycin or penicillin for 7 to 10 days. So you give a combination of both antitoxin and antimicrobials. Now the minimum protective level of antitoxin in our body is 0.01 to 0.1 IU per ml. So this is the treatment of diphtheria. Remember, this is the treatment of diphtheria. But what I want you to know is how to talk about an asymptomatic contact. So in your exam, definitely you'll get a question. What will you do to the friend of this child, to the household contact? So remember, all asymptomatic contacts should be monitored, should get serial cultures, and we give benzathine penicillin or erythromycin for 10 days to all contacts. We give benzathine or erythromycin for 10 days. Now the question is, erythromycin alone or you add a vaccine to this? So remember, DT vaccine is only given to children who have not received the fourth dose, or who have not received the booster in the last 5 years. So if I take you back to this question which I asked you, let's see if I can answer this question. So there's a 3-year-old child who is completely immunized. Sibling hai, is ladke ka sibling. So what will you do to a completely immunized sibling? You will give only erythromycin. Okay. If he was unimmunized, I would have given erythromycin plus DT vaccine. Okay, let's go further, guys. And now all of you, we know your examiners. We know they like to ask about recurrent pneumonia. So I want each one of you to know the life cycle of cystic fibrosis. All of you should know that, and I'm giving you this handout because I want all of you to know what happens in cystic fibrosis. During infancy, they can have meconium ileus, pancreatic insufficiency, foul smelling bulky stools. So most common cause of pancreatic insufficiency in the world in children is cystic fibrosis. Steatorrhea, fat malabsorption. Now in adolescents, they may have DIOS, distal intestinal obstruction. DIOS, distal intestinal obstruction. Intussusception. Okay, remember this, DIOS. All their life, please listen to me carefully, all their life sodium is low, chloride is low. All their life sodium is low, chloride is low, potassium is low. Hypochloremic, hypokalemic, hyponatremic, metabolic alkalosis. Remember this. Okay, very important, remember this. Now remember CB AVD, favorite question of your examiners. Absent vas deferens, congenital bilateral absence of vas deferens. So almost all men with cystic fibrosis have azoospermia because of bilateral absence of vas deferens. Okay, so if I ask you this question from NEET PG friends, what will you expect in an adolescent with cystic fibrosis? Dr. Rai is asking in the chat box, distal intestinal obstruction syndrome. So remember the second option, Dr. Rai in the chat box, DIOS, distal intestinal obstruction syndrome. Okay, rectal prolapse is rare nowadays, and remember sodium is always low throughout their life. Okay, remember, so the answer is DIOS. Okay, now remember, all your examiners like to ask about the mutation in cystic fibrosis. So cystic fibrosis is autosomal recessive, and the gene CFTR is on 7q31.2 locus. Remember, the gene 7q is on, the gene CFTR is on 7q31.2 locus, and the most common mutation is deletion of phenylalanine at the 508 number position. So most common mutation is deletion of the phenylalanine at the 508 number position. Okay, delta F508. So remember, the most common mutation in cystic fibrosis is delta, matlab deletion of the phenylalanine at the 508 number position. Remember, the CFTR gene codes for a chloride channel. Okay, now this is, remember, it is a class 2 mutation. Delta F is a class 2 mutation, and what happens because of this mutation is what happens because of this mutation is that it causes misfolding of the protein on the endoplasmic reticulum. The protein is misfolded on the endoplasmic reticulum and it causes a trafficking defect. The protein is not able to go to the cell surface. It causes a trafficking defect. The protein is not able to go to the cell surface. Okay, so this is how the new treatment of cystic fibrosis has emerged. Delta F508 leads to a trafficking defect. The protein is not able to go to the cell surface and make the chloride channel. Okay. Okay, let's go further. So remember, in respiratory system, all of you should know the GINA. You should know the stepwise management. So what I want you to remember is that in the step 5, now new biologicals have come up. So I've given you this in the handout. So I'll just tell you 2 points about this. For children 12 years or more and adults, for children 12 years or more and adults, the preferred reliever is a combination of inhaled steroid and formoterol. So remember, for children 12 years or more and adults, the preferred reliever is a combination of inhaled steroids and formoterol. And remember, in step 5, just remember step 5, we have LAMA, long-acting muscarinic antagonist, and new biologicals you can see here, anti-IgE, okay, which is omalizumab. Now for children 6 to 11 years, we still use salbutamol. So remember, in children 6 to 11 years, we still use salbutamol. We don't have evidence. See, hamara practice is evidence based. We don't have evidence for inhaled ICS formoterol. So for less than 11 years, we give salbutamol as a reliever. These are the steps for controller. And again, see, step number 5 has new biologicals. Okay. Okay. So let's go further and let's talk about the endocrine system. And in endocrine system, I want all of you to know that nowadays in every child of the world, we do heel prick. 2 बूंद जिंदगी के, और ये पोलियो के नहीं है. These are the 2 drops of blood on a heel prick, and we take these 2 drops of blood for screening. So mostly we do heel prick on day 3 to day 5 of life. And I will talk about 3 main newborn screenings, 4 main. First, I will talk about thyroid, TSH. Then I'll talk about congenital adrenal hyperplasia. Then remember, we also have a screen now available for other disorders, like it is called TMS, tandem mass spectrophotometry. This is a screen for metabolic disorders. So at birth, we can do a TMS, tandem mass spectrophotometry, for metabolic disorders. Then there are also screen for phenylketonuria called the Guthrie's test. So for phenylketonuria, we have a test called Guthrie's test, a microbiological test. So let's ask you a question from NEET PD last year. Let's talk about hypothyroidism. Congenital hypothyroidism. It is very common. Congenital hypothyroidism is seen in 1 in 2,000 live births, and 85% of the times congenital hypothyroidism is dysgenesis of the thyroid gland. Gland ही नहीं बना हुआ, dysgenesis of the thyroid gland. So gland ही नहीं बना हुआ. So what will be my first step? Now there is a controversy, guys, all of you. So remember, the first step is a radionuclide scan, a technetium-based radionuclide scan. So my first step will be a technetium-based radionuclide scan to look for the thyroid gland. See on your screen. I'll show you on your screen. This is a normal thyroid scan. So this is a normal technetium-based thyroid scan. See here. So when we do a normal scan, we see thyroid gland. We see some uptake in the salivary glands also. This is a normal gland. Now let's show you a child with dysgenesis. Now all of you, Can you see a thyroid gland anywhere? Can you see a thyroid gland anywhere? It is nowhere because bana hi nahi. So we do a technetium based nuclear scan to isolate the thyroid gland. So the first test will be a technetium based nuclear scan. Okay, I told you this, Dr. Gupta, just now. Now the second important question which will come in your exam is a 2-week-old baby with shock. So a 2-week-old baby comes to you in shock and has ambiguous genitalia. So has a phallus, has a penis-like structure, but testis is not there. This is called ambiguous genitalia. So what will you think of? CAH. So the second case scenario which can come in your exam is a neonate in shock with ambiguous genitalia, has a penis-like structure, but the testes are not palpable. Think about congenital adrenal hyperplasia. Congenital adrenal hyperplasia. Remember, very important, please put a line here. 90% of CAH is deficiency of 21 hydroxylase enzyme. 90% is 21 hydroxylase deficiency. Okay, so aldosterone is not formed, cortisol is not formed, and testosterone is increased. So males get precocious puberty. Males get precocious puberty while females get virilized. So males get early puberty while females get virilized. Okay, so can you see what accumulates? 17 hydroxyprogesterone. Can you see 17 hydroxyprogesterone accumulates? So how do we diagnose CAH? By elevated levels of 17 hydroxyprogesterone. The levels are in thousands. I gave you this in the handout. So levels are more than 3500 to 5000 nanograms per deciliter, or more than 100 to 150 nanomole per liter. Okay, okay, remember this. So salient points about CAH. Remember, it is the most common cause of a female pseudo hermaphrodite. It is genetic. It is autosomal recessive. Autosomal recessive. Female looks like a male. Female pseudo hermaphrodite. Okay, and the test is 17 hydroxyprogesterone. So every baby in the world gets 17 hydroxyprogesterone. Your first step in a child with shock, this child is in shock, is to go give a bolus of normal saline. And remember, the treatment of adrenal insufficiency is to give hydrocortisone. So drug of choice for adrenal insufficiency is hydrocortisone, plus you also give oral fludrocortisone. Plus you also give oral fludrocortisone. Cool? Let's go further to another endocrine condition. All of you, how's the Josh? How are you enjoying the class? Let me know in the chat box. Enjoying or not? Let me know. Let's take you to a very important mnemonic and just write 21, 17 and 11. M means mineralocorticoid. M means mineralocorticoid. And T is testosterone. And T is testosterone. So this, and you know, one ko bana do arrow. One means arrow. So it means only testosterone is high in 21. Mineralocorticoid is not. In 17, only mineralocorticoid is high. Testosterone is not. And 11, dekho 11, both of them are high. So in 11, both mineralocorticoid and testosterone are high. All of you, let me ask you a question and you answer in the chat box. In which CAH there is hypertension because of mineralocorticoid excess? In which enzyme deficiency of CAH? I have written here 21, 17 or 11. In which enzyme deficiencies of CAH there is hypertension? (17 and 11). So this in 17 and 11 mineralocorticoid is high. So there is hypertension. So BP is high in them. So which CH are virilizing? 21 and 11. Okay. So let us talk about short stature, guys. Let us talk about short stature. So all of you should know the most common cause of short stature is this third line from below. This third line from below. This blue line is constitutional short stature. This child was born normally, but he got a lag. Can you see? He got a lag, and later in his life he could catch up. When he became an adolescent, he could catch up later in the life. So most common short stature is constitutional. They catch up later in the life. Okay, so these constitutional short statures have delayed puberty and delayed bone age, delayed puberty and delayed bone age, and they catch up later in the life and they become normal. So in English they say these children are late bloomers. These children are late bloomers. In English they say late bloomers. हिंदी में थोड़ा सा कहूँगा, शक्ति कपूर जी कहा करते थे, जब भी वो किसी लड़की को देखते थे कहते थे ये वो कच्ची कलिया है जो देर से खिलती है. So ये वो, so Shakti Kapoor ji, I don't know how to express this in English. He used to say, you know, late bloomers is constitutional short stature. So what is familial short stature? Familial short stature is right from the beginning this child is small and remains small. This red line is familial. They are small right from the beginning and they remain small. So puberty and bone ossification is always normal in familial short stature. Please remember, puberty and bone ossification is always normal in familial short stature. Okay, let's take you to nephrology now. So I have just two more systems to go, nephrology and neonatology. So in nephrology, all of you should be aware, this is a very common question in your exam. If mother has oligo, NEET PG last year, if mother has oligohydramnios, क्या सोचोगे? Bachcha has kidney problem. Kidney makes the amniotic fluid. So think about Potter's. Think about Potter's sequence. Okay, think about Potter's sequence. Okay, so Bachcha has kidney is not formed, mother gets oligo, and this causes pulmonary hypoplasia. Okay, so this, instead of a syndrome, we say it's a sequence. Okay, so think about kidney problem in severe oligohydramnios. Now remember that nowadays a lot of questions, I can tell you guys, I'm a pediatric nephrologist, I'll tell you about myself later. So a lot of questions come on the new guidelines. So all of you should know that the most common cause of UTI is this. What is this on your screen? This is vesico-ureteric reflux. So most common cause of UTI in children is vesico-ureteric reflux. This is MCU on your screen. It's a test called micturating cystourethography. It's MCU on your screen. And you can see urine is refluxing to the upper system. So for recurrent UTI, we do all tests, all three tests in children called ultrasound, MCU, and a DMSA nuclear scan. So if you have a child with the recurrent UTI, think of three: ultrasound, DMSA, and MCU. Okay. Now, if a child has first episode of UTI, we get ultrasound in all. So in the first episode of UTI, get ultrasound in all. Okay. If ultrasound is abnormal, or if this child is less than 3 months old, or if this child has got non-E. coli UTI, small children, you should get a MCU. So when do we get MCU nowadays? If ultrasound is abnormal, child is less than 3 months, non-E. coli UTI. Now DMSA nuclear scan tells us about scarring. So DMSA nuclear scan tells us about scarring. So scars happen late. So nowadays we do DMSA nuclear scan after 4 to 6 months of UTI. So remember, nowadays we do a delayed phase DMSA to look for scars after 4 to 6 months of UTI. I would just say one more thing. in always recurrent UTI, look for bowel bladder dysfunction in girls, bowel bladder problems in girls. All of you, if you have a sister in your house who is 5-year-old, 7-year-old, you will see she will never go to the loo in school. Okay, कि school का loo तो गंदा होता है. She will have constipation. There would be days she would not do potty at home. So I can tell you guys, I run a very busy clinic in Gurgaon, and half of my patients are constipated. Half of my day goes on to tell the parents, you accept that your child is constipated. So yeah, half of my job is to treat constipation. Then let's talk about the new guidelines for nephrotic syndrome in children. And the new guidelines for nephrotic syndrome in children is that for first episode of nephrotic syndrome, we give prednisolone for 3 months for 12 weeks. But if a child is frequently relapsing, if a child is frequently relapser or steroid dependent, if he is frequently relapsing or if he is a steroid dependent, the first drug is low dose alternate day prednisolone. Low dose alternate day prednisolone for almost 1 year. We give low dose alternate day prednisolone for almost 1 year. Now, if this child is having a high threshold, he relapses on a very high dose of steroid, high threshold. Or if he gets complicated relapses, every relapse he is admitted, we give oral mycophenolate. So nowadays we have a new drug called MMF, oral mycophenolate mofetil. So we give oral mycophenolate mofetil for 1 year, and especially for children more than 8 years, we give oral cyclophosphamide for 12 weeks. So drug of choice for children more than 8 years is oral cyclophosphamide for 12 weeks. Now, if this child is a mild child, the drug of choice is oral levamisole. Okay, is oral levamisole. Now, what is steroid resistant? So again, we have changed the definition, friends. Again, now we have changed the definition. So steroid resistant is now no response for 4 weeks of prednisolone. 4 weeks. We do a kidney biopsy to look for FSGS. So in steroid resistant, we do a kidney biopsy to look for FSGS. And the drug of choice for steroid resistant is tacrolimus. It's a calcineurin inhibitor called tacrolimus. So remember, drug of choice for steroid resistant nephrotic syndrome is tacrolimus. Cool? Tacrolimus. So we said if there is no response to steroids for 4 weeks, we label the child as steroid resistant nephrotic, and we go for kidney biopsy, and then we give tacrolimus. Okay, so this is written on your screen. So this is our protocol. Okay, if the child has steroid toxicity, we give, he's an older child, give in steroid dependence, give cyclophosphamide for older children. Otherwise, give steroid dependent छोटे बच्चों में mycophenolate. Okay, so let's go further and let us take you now to that every patient, your examiners will definitely start asking you about a condition called hypochloremic hypokalemic metabolic alkalosis. So if a child is vomiting like pyloric stenosis, he is vomiting. Multiple vomitings will cause loss of acid, metabolic alkalosis. So all of you should know that in your exam, they will ask you a differential of hypokalemic, hypochloremic, metabolic alkalosis. So today we told you chronic vomiting can cause metabolic alkalosis. Pyloric stenosis can cause metabolic alkalosis. Today we showed you cystic fibrosis can cause metabolic alkalosis. Okay, then what about if this child has high BP? High BP, Liddle syndrome. Liddle syndrome is epithelial sodium cotransporter activation. Hyperaldosteronism will also cause the same problem, hyperaldosteronism. However, if this child has polyuria, think about diuretic abuse, Bartter syndrome, or Gentleman syndrome. So if he has polyuria, think about Bartter syndrome or Gentleman syndrome. So please remember this state: hypokalemic, hypochloremic, metabolic alkalosis. Okay, let's go further. So this we have done. Let's lastly talk about neurology. So we can show you, this is a child who came to you with some abnormal jerks. This is an infant. Bilateral symmetric flexor contractions. Can you see? Bilateral symmetric flexor contractions, infantile spasms, seen between 2 to 12 months of life. Seen between 2 to 12 months of life. They're also called salam seizures. They're also called salam. It's looking like a salam. They're infantile spasms. Now, all of you should know that what is a typical EEG of infantile spasm. This is common in NEET PG. Every NEET inicet, hips arrhythmia, all over the brain, generalized chaos. So you can see a generalized chaotic pattern of high voltage slow waves. Generalized chaotic pattern of high voltage slow waves. Okay, is infantile spasms. So remember, all of you should know what is West syndrome. West syndrome is a triad. Remember, all of you remember, West syndrome is a triad of infantile spasms, hips arrhythmia, and developmental delay. So West syndrome is a triad of infantile spasms, hips arrhythmia, and developmental regression. So remember, drug of choice for infantile spasms is intramuscular ACTH. Only for tuberous sclerosis babies, the drug of choice is oral vigabatrin. Only for tuberous sclerosis babies, the drug of choice is oral vigabatrin. Okay, let's go further. Let's go further. And what I'll do is, I'll show you a child whose name is Ali. He's not doing well in school, and he also has a sister. All of you please promise me you will not look at his sister. I will show you a video, but please don't look at his sister, okay? So did you see? He just gave a blank stare, and there was no aura, there was no post-ictal phase. Suddenly he gave a blank stare for lasting few seconds. And I know all of you were looking at his sister. She was a typical, attention-seeking female. So I'll show you one more child from Haryana. See this.
Excuse me, ma'am. किस तरह होती है? दोनों आ रहे हैं. जोर से करो. जोर मार.
Can you see? She is hyperventilating. We are asking a girl to hyperventilate, and she's hyperventilating, and I need to re-edit this video. This is a video from Haryana. She's from Haryana. And can you see? She just gave a blank stare lasting few seconds. Can you see? Baba ji bhi bol rahe, yahi hua hai. So hyperventilation provokes absence seizures. Okay. So remember, hyperventilation provokes absence seizures. And the typical EEG is all over the brain, generalized. Every second there are 3 spikes. All over the brain, generalized. Every second there are 3 spikes. Spike and wave, 3 spikes and wave per second. The drug of choice for absence seizures, typical absence seizures, is always ethosuximide. So remember, the drug of choice for typical absence seizures is ethosuximide. Okay, and all of you, this is Dr. Achin. You just met him yesterday. Don't ever ask us the drug of choice for absence seizures. The drug of choice for typical absence seizures is always ethosuximide. Otherwise, Dr. Achin, you just met him yesterday. He will come with his punching bag. Okay, so all of you, I have an adolescent girl coming to you. Now tell me, what's she talking about?
Woke up from a nap and figured it's good timing. Well, not good timing at all, because it's never good timing for myoclonic seizures, especially when it's 4:03 in the afternoon. I took a nap for a few hours and I woke up like 10 minutes ago. Well, maybe long, maybe like 20 minutes ago, and like I started having my jerks, and and and
So what was she talking about? She was telling you that she had the most common generalized epilepsy in adolescents and young adults. The most common generalized epilepsy in adolescents and young adults, called juvenile myoclonic epilepsy. This video is there on YouTube. Just, how girls are, everything, whenever they get up in the morning, first thing they do is they make their own Instagram video. So there are many Instagram reels on this. There are many YouTube videos on JME My Story. So these girls get up in the morning and they get these jerks in the morning. So they get these jerks, they get these drops in the morning. Okay. And later 90% of them present to the doctor with GTCS. So 90% of them, okay, they present to the doctor with GTCS. 1/3 of them can also present with absence seizures. 1/3 of them can also present with absence seizures. Now this is the typical JME EEG. Polyspike and wave all over the brain. So 4 to 6 hertz, 4 to 6 hertz, it's a faster 4 to 6 hertz polyspike and wave discharges. Okay, and the drug of choice is levetiracetam. And the drug of choice is now not valproate, it's levetiracetam followed by valproate. Okay, it's levetiracetam followed by valproate. So all of you, today I told you, remember, absence seizures is ethosuximide, focal epilepsy is oxcarbamazepine and carbamazepine, generalized seizures, the drug of choice is levetiracetam. For infantile spasms, we give ACTH, but only for tuberous sclerosis babies, we give vigabatrin. And even for JME, we give levetiracetam. So that was all I wanted to tell you about systemic pediatrics. Guys, I will keep on seeing you. Maybe once you become a PG, I'll see you on the other side. I will be a grumpy consultant, scolding you. This is what I do in my hospital. I'm not just a DAMS faculty, I'm also a pediatric nephrologist since last 13 years. I'm a pediatric nephrology head at this hospital. On the 12th floor, here is our department. We do the largest number of kidney transplants in children and adults in our hospital. And this is one of the child from Jabalpur, Madhya Pradesh, whom we transplanted almost 10 years back. He is now an 18-year-old boy. This is a child who is now an engineer in Philippines. This is a girl from Africa whom we transplanted 10 years back. She is now a tall, beautiful female. She has changed, and so have I. We all change as we grow. So I have many friends like this. Why am I talking about all of this is because, I enjoy doing this. Every day of my life, I go to my clinic, I go to the ICUs. Half of my life is doing dialysis and all of those stuff in sick children. I'm passionate about this. I love to do what I do. So, learning is a lifelong process. So enjoy learning, enjoy working, join the branch which you want to do. Okay. So I have just one thing to say, all of you, that you should join what you want to do. Don't think that if you got a first rank in NEET PG, someone told you that this branch is picked up by every first ranker. No, you do what you do, you love what you do. I think this matters more than money. So all of you, please follow your dreams, and your dreams also know your way. So follow your passion. I am available on all social media platforms. If you have any doubts, feel free to tag me on any social media platform. Thank you, and see you on the other side when I will be the grumpy consultant, seeing your patient and scolding you badly. Okay, sorry for that. And on behalf of the DAMS family, all the best.